Moving on to the next topic, which will be cardiomyopathy. So we have three basic types of cardiomyopathies, starting from dilated cardiomyopathy, then hypertrophic cardiomyopathy, then restrictive cardiomyopathy. So first thing we'll be seeing about is dilated cardiomyopathy, which is the most important of all. So the dilated cardiomyopathy, it is going to have various causes. So both genetic and other causes as well. Under genetic causes, we have the most important one being autosomal dominant kind of inheritance, which is due to a titin mutation. So titin is one of the muscle proteins, right? And it is the largest protein which is seen in the body. And it can also be inherited as an autosomal recessive or an X-linked manner. So in X-linked disorders, we have two types of diseases, which is Duchenne's muscular dystrophy and Becker's muscular dystrophy. So in Duchenne's muscular dystrophy, this dystrophin protein, which is again a muscle protein, is going to be absent, while in Becker's, it is going to be deficient. So that is the basic difference between these two diseases. So the protein here, which is mutated, will be dystrophin. But if they ask for the most common mutation, it will be titin. Okay, titin will be the most common mutation. Coming to the other causes of DCM, which will be alcohol, which is the very, very important cause of DCM. So alcohol being the most important cause of DCM. Other than that, we can also have viral infections like Coxsackie B, which can lead to myocarditis and resulting in cardiomyopathy. And also postpartum females. So post-pregnancy, these females will have this hemodynamic changes that can again result in DCM. Other than that, we have cobalt and hemochromatosis. So listen carefully, hemochromatosis can result in both DCM and restrictive cardiomyopathy. So DCM will be more common than a restrictive cardiomyopathy in hemochromatosis. This is one of the controversial questions. So remember this. So how will the heart appear in a dilated cardiomyopathy? So as the name suggests, the heart is going to be dilated. Okay, all four chambers of the heart will be dilated and the heart is going to be very thin and flabby. So if it, in this picture, if you appreciate, all the four quadrants are being dilated in this, and it is having a thin flabby wall. And the most important part of it is when all four chambers are dilated and thin, it is not able to contract properly. So it will result in a systolic dysfunction. This is the only cardiomyopathy resulting in a systolic dysfunction. Rest all cardiomyopathies result in a diastolic dysfunction. So on microscopy, how does this DCM look like? So if you see, myocyte hypertrophy and atrophy is common for all kind of cardiomyopathies. Other than that, we have a specific feature for DCM, which is called as ninja star kind of a nucleus. So if you have seen cartoon images, you can see this is the ninja star in cartoons you see, right? So this kind of a nucleus, which is dark and hypochromatic. So all these nucleus which are highlighted, no? So these are having this ninja star kind of appearance. This is classical for a titin mutation, which is seen in a DCM. Okay, now we had seen about dilated cardiomyopathy. Then next we'll move on to hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy is always genetically acquired. So 100% genetic causes will be the cause, and here it is going to be autosomal dominant. And there can be various mutations, but the most common of which will be beta myosin heavy chain mutation. So this is again a myosin is a muscle protein, right? So beta myosin heavy chain protein mutation will be seen in hypertrophic cardiomyopathy. And the classical history which will be given for a hypertrophic cardiomyopathy will be that of a young athlete, like he'll be playing basketball or something and suddenly he collapses and perishes. So this kind of a history will be given for a hypertrophic cardiomyopathy. And what is the gross appearance of hypertrophic cardiomyopathy? Here again, the heart will be dilated. The heart will be enlarged. And the heart will be very thick walled. Unlike a DCM, here it is going to be thick walled. So the most important thing which we remember about hypertrophic cardiomyopathy is interventricular septal hypertrophy. And this septal hypertrophy is going to be asymmetric. So this entire part which we see here, no, this is the interventricular septum. So look at it, it has become quite large, right? So it will be asymmetric kind of an hypertrophy of this interventricular septum. Since this interventricular septum is becoming so big, it is going to compress the left ventricle, and this is the left ventricle which has become literally compressed like a banana. So this banana like configuration of the left ventricle associated with the asymmetric hypertrophy of the interventricular septum will be the classical findings which we see in a hypertrophic cardiomyopathy. And like I mentioned, it is going to result in diastolic dysfunction. And since this left ventricle is being obstructed, it will also obstruct the outflow of the left ventricle. And here, because of this left ventricular outflow obstruction, we can also hear a systolic ejection murmur. Okay, systolic ejection murmur can be heard. So how does this hypertrophic cardiomyopathy look on microscopy? Again, myocyte hypertrophy and atrophy will be seen. Other than that, we have this disarray of this muscle fibers. Normally, the muscle fibers are all parallel like this. But in this picture, if you see, it is all going this way and that way and like branching. So this is what we call as helter-skelter disarray of the myocytes. This is the classical feature we see in a hypertrophic cardiomyopathy. Then we will see about the next type of cardiomyopathy, which is restrictive cardiomyopathy. Here, the causes of restrictive cardiomyopathy can be numerous in number, especially it will include the inborn errors of metabolism. So, any kind of deposition in the cardiac muscle is going to result in this restrictive cardiomyopathy. So, the most common cause of restrictive cardiomyopathy will be amyloidosis. And then we can also have radiation-induced fibrosis. So, the fibrosis is also kind of a deposition that is going to cause the restriction of the heart. So, the heart cannot dilate properly. So, diastolic dysfunction is going to be present. There will be fibrosis. So, the heart cannot relax properly. Okay. So, metastatic tumors again can cause the same thing. There will be metastasis which will prevent the proper diastolic function of the heart. And here there will be biatrial dilatation while the ventricles will be of the normal size. So the most important thing I mentioned was hemochromatosis. Even though if it you can think it is iron kind of deposition, but here hemochromatosis will be present more in DCM, will present with DCM more than restrictive cardiomyopathy. Next, we'll move on to certain subtypes of dilated cardiomyopathy, and these subtypes are the ones which are more potential for being asked in the MCQs. So, starting with Takotsubo cardiomyopathy, like I mentioned, it is going to be a variant of dilated cardiomyopathy. And you must have seen in movies also, like hearing some sudden shocking news, the heroine collapses or someone collapses in the film, right? So, why is it? Probably it is due to this Takotsubo cardiomyopathy only. So what happens is, during when they hear these kind of shocking news or something, there will be supraphysiological stress. So that stress induced catecholamine release will be there. So large amounts of catecholamines will be released, and these catecholamines will cause stunning of the myocardium. So the myocardium will stop contracting. So it will be stunned. So because of that, there will be contraction band necrosis of the myocytes. So these pink areas, if you see, so these kind of rugae we are seeing, no? So these are nothing but contraction band necrosis. So this is again a classical feature we see in Takotsubo cardiomyopathy. And the most important one of which will be, there will be no ECG changes seen in Takotsubo cardiomyopathy. So how does this name Takotsubo come? Because Takotsubo is a kind of a trap or pot they use for capturing octopus in Japan. So this heart actually looks like this trap. So that is why this cardiomyopathy has been given the name Takotsubo. So this is the normal heart, this first image, and if in the second image, if you see, the ventricle has been enlarged, and that is because there will be this base of the heart is going to be very much hyperkinetic. However, the apex of the heart will be stunned and it will be hypokinetic. So this is contracting while this is just standing like this, and this apex of the heart is going to get dilated, and it is going to look like a pot which resembles the Takotsubo, and that is why it is given this name. So the most important thing about Takotsubo cardiomyopathy will be, it is a type of DCM induced by catecholamines, and it is going to cause no ECG changes, and the pathogenesis involves increased catecholamines resulting in myocardial stunning and contraction band necrosis. So this is one of the most important potential MCQs which can come. Next, moving on to the next type of cardiomyopathy, which is arrhythmogenic right ventricular cardiomyopathy. So as the name suggests, there is going to be arrhythmia, and it is going to affect the right ventricle. Here again, it is a type of dilated cardiomyopathy only, and this will result in right ventricular heart failure. So what happens here is, actually, this is the right ventricular wall. Here the wall, instead of being muscle, it is appearing yellow, right? So this left ventricle, if you see, this is all brown in color, which is the muscle. But here this wall present in the right ventricle is seeing yellow and white in color, right? So there will be fatty and fibrotic material depositing in the right ventricle, which is actually causing this cardiomyopathy. So the second image here which we see, it is the empty stain. Empty stain is Mason's trichrome stain. In this stain, if you see, this red area will be the normal muscle. Okay, so the normal muscle, this entire part should have been red in color, but we see this white color areas and blue color areas, right? So these white areas are nothing but the fat, so adipose tissue deposition, and this blue color areas are collagen, which is stained blue by the Mason's trichome stain. So because of this, there is going to be dysfunction of the right ventricle, resulting in right ventricular heart failure. So this right ventricular heart failure is going to be associated with a syndrome called as Naxos syndrome. So this is also an MCQ. So Naxos syndrome is nothing but there will be this arrhythmogenic right ventricular cardiomyopathy associated with hyperkeratosis of the palms and the soles. Along with that, the patient can also have woolly kind of a hair. So like a wool, the hair will appear like wool. So woolly kind of hair can be seen. And the most common mutation associated with Naxos syndrome is a plakoglobin mutation. This is going to be a desmosome which is being mutated. Okay, so it is going to result in arrhythmia and heart failure. So now we had seen about the various types of cardiomyopathy. So look into the history for clues. So if they mention some postpartum female or alcohol or hemochromatosis, probably they are pointing towards a DCM. Suppose they are giving history of a young athlete collapsing, they are probably giving clue to a hypertrophic cardiomyopathy. Suppose they are mentioning about amyloidosis. So amyloidosis or some radiation history has been given. Probably they are mentioning about restrictive cardiomyopathy. And if they are giving some supraphysiological stress kind of a symptoms, then they are referring to the Takotsubo cardiomyopathy. So the history will point towards it, and rest of the theory you will need to know to answer the MCQs.